Hi, welcome to the Dog Dave Show. Thank you again for joining us today. Today I decided to talk about a controversial topic about sexual health. It's because the prevalence of sexual diseases is growing all over the world in terms of gonorrhea, syphilis, and HIV and other things. But people are reluctant to talk about those things. The purpose of this show is to educate people and to raise awareness so that we can prevent these things if it's possible. And also it's a platform for health professionals to debate about these things. So today, to help me talk about sexual health in particular, STIs, also called sexually transmitted infections, is Dr. Arun Menon. He's a sexual health specialist. Dr. Menon, thank you so much for coming to my show.
Pleasure.
Right, thank you. We agree. I was really hunting for you, and I couldn't get out of you for the past 6 months or so. I appreciate that you've come to the platform.
No worries.
You have done extensive training. You trained in England, and you did public health, and then you came to Australia and New Zealand. You did sexual health, basically. Is that genital urinary medicine? Is that right?
Yeah.
Yeah, that's okay. And now you're here in Townsville, Queensland, part of Australia, and you are managing this department, which is massive and covering different towns. And you appear to be the only one who's doing this, which is why it's hard for you to to come to the platforms like this. But I really appreciate that you've come to us here today. And your department, you do deal with lots of sexual health issues.
Yes.
Yes. Yeah. If you can just give us a narration of what you do in your department.
So traditionally, people think about sexual health clinics as dealing only with STIs.
Right.
But in fact, STIs are a small part of our business.
Right.
Yes, we certainly deal with STIs, but we also have expertise in reproductive health and all aspects of reproductive health, from contraception and various forms of contraception, including long-acting reversible contraception, through to provision of medical terminations.
Yes.
We also deal with transgender issues. We have quite a significantly growing population of young adolescents who are transgender. We deal with all the bloodborne viruses, including HIV, hepatitis B and hepatitis C. HIV is really also quite a small part of our business.
Right.
We do a lot of sexual function work.
Yes.
We do a lot of dermatology as well.
Okay.
So we encompass the entire range of sexual health issues.
That's right.
And so we don't just concentrate on gonorrhea or chlamydia.
Yes.
Many of those things are very straightforward to deal with. And one of the reasons why sexual health clinics exist is because general practitioners are very reluctant to deal with simple sexual health issues.
Yes.
For instance, how many times have you written a script for, an antihypertensive?
Oh, we do this all the time.
Exactly. Do you ever discuss the relevance of an antihypertensive medication on sexual function?
Yes, some medications, yes, we do mention, again, depending on the age group. Yes.
Exactly. So what we find is that, we exist because not because the things we do are complex. Unlike your general cardiologist who might put in stents and things, nothing we do is that dramatic or complicated. But we exist largely because other health professionals don't want to talk about sexual health issues.
Yes.
For instance, if you take general practice, only 1 in 100 consults is related to sexual health, and most of that is about cervical screening rather than about sexual health issues.
Yes, which is why we encourage discussions regarding some of these taboo issues.
Well, there is no discussion of taboo issues. If you take JCU, for instance, here, sexual health is only a very small component of their training program. So we come in the third year. I think we have a total of about 5 hours in the third year. We have a couple of hours in the fourth year. They have a few sessions in the first year. So most of the students that come out are inherently incapable
Yes.
of talking about sexual health issues.
That's right. I'm included too. I mean, the kind of training we went through. I mean, sexual
Exactly.
health, including dermatology, is just 1 or 2 weeks, and that's it, sufficient.
Yeah.
And yet we see these scenarios a lot in the primary care settings. And yes, like you said, we are sometimes ill-equipped or ill-skilled to tackle these things. In terms of consultation, let's say you're dealing with a young adult who's coming in, let's say just for a pill, for instance. We are supposed to be talking about STIs as well.
No, I think the conversation is less complicated than most people imagine. You know, if a young woman comes in for contraception,
Yes.
you know, the simple question is, have you ever had a sexual health check? Or have you ever changed your partners? You don't need to go into the mechanics of it. It's
Right.
a very simple and straightforward conversation. Have you ever had a sexual health check? If you've not had a check, we can offer you a check.
Yes.
You know, what would a sample of urine perhaps, or even a self-applied swab? So it's not a complicated thing. I think
No,
there's
it's
just a
not.
general reluctance to discuss these
Yes,
things.
that's right. That's right.
And that's what all the studies show.
And also from the patient side of things, especially the young adults who come with some issues, they're also not forthcoming in terms of talking about their sexual history. Especially the men, I find that
Sure.
they feel like they're put in the spot, basically, and they try to dodge the question as much as possible. What then do you encourage health practitioners to do in that sense? Is it retraining, or what do you encourage?
I think, I mean, certainly at med school level, it needs to be an essential part of the curriculum, because, you know, maybe I'm biased, but I do think, you know, sex is really important to most people, even though we don't talk about it.
Right.
We use sex to advertise everything, but we don't actually talk about the issues that matter. You know, for instance, I think it's a straightforward issue. I don't think you need to, we are overthinking it in terms of providing services.
Right.
It just needs to be simple.
Yeah.
It's just like, well, someone comes in with high blood pressure. What do? You give them a talk about diet, exercise, and all the rest of it. And I think people come in, it's very legitimate to talk to a diabetic, for instance. Tell me how things are going for you as far as sex is concerned. Are your erections still okay? For women, are you getting pain? Are you getting, you know, recurrent vaginal symptoms?
Yes.
I think the conversations are straightforward if you have them in the context of the patient. What we find is, and a lot of the patients that present to us because their carers are not willing to discuss the issues that matter to them.
I see.
So, you know, we're finding that it's not just about disease, it's also about talking about sexual pleasure, about possibility, and doing it in a way that's not judgmental.
Yes.
So, and I would agree with you. I think a lot of people need more training, but I think it needs to be simplified. We're far too complex in the way we approach sexual health.
Right. Well, it's for the sake of, let's say, the general population, and aside from the medical world. A woman comes here, I'm saying, I'm discharging from down below my vagina. I got this stuff coming out. What's your thoughts?
Well, it's just like any other part of medicine. Someone comes to see you, David, they've got a chronic cough. You're going to say, when did the cough start? How long have you had it? Is there anything that makes it better or worse? Is there any blood in it? Do you smoke? And it's the same approach. You know, the questions are, you know, duration, when did it start? Have you done anything about it?
Yeah.
And then in that mix, you can throw in, you know, are you sexually active? And, you know, are you in a relationship? Have you had unprotected sex with a casual person? And that will determine the path that you take it down.
Yes, that's from the general point, from the medical point of view. How about from the young woman who's watching? He hasn't shared this information with anybody, and she is producing all this stuff. It could be itchy, may not be itchy, but she's discharging. How can we encourage those people to come forward to seek help?
I think that if you have symptoms that you're not comfortable with, that you don't recognize, you should go and see your a health practitioner who you're comfortable with.
Yes.
Because inevitably they will ask you, particularly if you've got genital symptoms or anorectal symptoms or oral symptoms, they should ask you about your sexual history.
Yes.
Now, it doesn't have to be confrontational. It's very simple.
Yes.
It is dramatically simple. I think we overthink this idea that it's complicated. It's not.
It's not. No, that's right. That's okay. Now, in general, looking at the literature anyway, I mean, we know that chlamydia is one of the commonest conditions we see in primary care. But we also see gonorrhea. I was checking the statistics in England, for instance. I mean, they had cases in 2017 alone, there were about 7,000, I think, 7,160 cases in 2017, cases of gonorrhea. And also the trend of picking up syphilis has just skyrocketed, again in England as well. And yet we are finding that gonorrhea is becoming resistant to antibiotics, conventional antibiotics we've been using. What's your thoughts in that area regarding gonorrhea, syphilis, and then another one which is rarely tested, as we talked before the session here, Mycoplasma genitalium?
So, in one of my other roles, I work as a clinical advisor to the international division of the Australasian Society of HIV, sexual hepatitis, and sexual health medicine. And we run projects in the Pacific and in Papua New Guinea. The trend around the globe is increasing numbers of STIs, particularly gonorrhea.
Yes.
And only a small proportion of those people are adequately tested and treated. Okay. So this is a worldwide issue. As you probably know, that gonorrhea is becoming increasingly resistant to first-line medications. That's and right. That trend was first noticed in the UK, but we've had cases here in Australia as well. In Australia too, we have the world's largest heterosexual outbreak of syphilis.
Syphilis. In the world?
In the world, bar none. Okay, we're nearly up to 2,500 cases.
Yeah, that's man and woman, heterosexual.
It started off in the northwest part of Australia, but now it's spread everywhere, including a couple of weeks ago there was an article in The Age in Melbourne, right, which sort of outlined how important an infection syphilis was becoming in the heterosexual population. So we're not talking about syphilis being confined, we're talking about it being out of control.
Yes.
And so much so that in North Queensland, for instance, we've had, I forget, about 15 cases of congenital syphilis, and we're regularly getting congenital syphilis. Recently in Southeast Queensland, we've had 2 cases of congenital syphilis, whereas the WHO standard is 0.
Could you just explain to the people watching what congenital syphilis is?
Congenital syphilis is when syphilis is transmitted from the mother to the baby, and it has severe consequences. I mean, either you can lose the pregnancy, or the baby becomes quite sick.
That's right.
And there's a risk of certainly a risk of death, neonatal death. And then we have additional issues. So gonorrhea is moving from being fairly easily treated to becoming quite complex in its treatment now. Syphilis, fortunately, is still sensitive to penicillin, so it's not too much of an issue. The other organism you mentioned was Mycoplasma genitalium, and that's a nightmare because Mycoplasma genitalium was first I think identified in 1981, but it's only slowly entering the consciousness now, and it is an extremely resistant organism. First line treatment is 11 days, second line treatment is 14 days, and third line treatment is 10 days. So what we're in a situation now where we're running out of antibiotics to deal with Mycoplasma genitalium. So it's going to be a huge problem for us.
Right. And that's across the world, is that right? Yeah.
That's across the world.
Yes, yeah.
It's across the world as far as gonorrhea is concerned. It's across the world as far as syphilis is concerned. It's across the world as far as mycoplasma genitalium is concerned. Chlamydia is relatively easy to treat, easy to diagnose, and easy to treat.
Yes.
If you ask me why we're sitting in this epidemic, it's very simple. It is we're not testing enough and treating enough people, even though we have the technologies available. Most of the time, you can diagnose most sexually transmitted infections simply through PCR testing.
Yes.
People can do they can do their samples themselves, and they can be sent off for analysis.
Yeah. So there's a vaginal and urethral swab, isn't it? Yeah.
The other reason why people are not we're in the midst of this outbreak is because most infections are asymptomatic.
Yes.
So people simply don't know whether they've got the infection
or not. Yeah.
They think that because they're asymptomatic, they're not at risk of either acquiring the infection or passing on the infection.
Yes.
So I think those are the two main reasons we're not testing enough, and it's an asymptomatic infection.
So if we come back to gonorrhea, for instance, what's usually the presentation? Just again, this, for the sake of the general population.
Look, we have an outbreak going on in Mackay at the moment, which is just 400 k's to the south of us. The majority of diagnoses are in women who are asymptomatic. Right? Men will certainly present with symptoms, but most women do not present with symptoms.
Yes.
And therefore, the question is not so much you should test when people present with symptoms. They should be tested really in other situations. If they turn up for contraception, if women turn up for contraception, if men turn up for other issues,
yes,
they should be asked the question. Just like you would routinely test a person who's overweight for diabetes, or take their blood pressure.
Yes.
I think people should be offered a sexual health check in every situation that it's possible.
That's right. And in men, it's predominantly for gonorrhea, it's just penile discharge, isn't it? Urethral discharge. Yeah.
No, it can be, but it can be asymptomatic as well. I think you can't diagnose people on the basis of symptoms. Because most of the infections are asymptomatic.
Right.
You have to diagnose people on the basis of risk. Have they been at risk of acquiring an infection? And that's really the main criteria for testing. Certainly you should be testing people if they're symptomatic, but if they're asymptomatic, you should be offering them a test, depending on their individual circumstances.
Yes. Yeah. And we're looking at risk groups. For instance, we're looking at what, age group, maybe up to 24, 25-year-olds, or anybody?
The idea that risk groups exist is we're moving away from the idea that risk groups exist.
Okay.
Certainly if you got, met your partner at the age of 18 or 19 and you're married to them for 70 years, you're not going to be at risk. But people change their relationships all the time. People are economical with who they're having a relationship with. Okay. People are economical about what type of relationship they're having.
That's right.
And also you have to take into account the appearance of social media now. There are a lot of people who are, on Tinder, on Grindr, on a whole range of these hookup apps, as we call them. And the hookup apps have been responsible for certain increases in certain parts of the world. So the whole landscape has changed.
Changed completely.
It's not, it's a bit like, if you like, I think half the Australian population is obese now. So, that conversation has to address that. Likewise, in sexual health, we're moving away from this concept that, only certain people get certain things. That's not really true anymore.
Yeah. It used to be like a prostitution or sex selling and intravenous drug usage and stuff. But now people, like you're saying, the social media, people are just doing things secretly, pretty much. They're just in that category whereby they are visible. And yeah, social media is very powerful in that regard, yes.
So we say, for instance, you know, Australia has a problem with hepatitis C and hepatitis B as well. So we've got, you know, I think we probably at the last count we have something like 160,000 people with hepatitis C. We're only going to get on top of that outbreak if we start testing people. And you have to test people who may not consider themselves at risk. It's the same with hepatitis B. It's the same with HIV. HIV in this country is now being transmitted by people who don't know what their serostatus is.
Yes.
Most people who know what their HIV status is and are on medication are non-infectious. Right? The medications for HIV are so good now that as long as you take your medication, your viral load is suppressed. It doesn't matter what kind of sex you have. It doesn't matter whether you inject. You know, you're not going to pass on the infection. So the key message here is that it doesn't matter who you are, which risk group you are in. You should get yourself checked out at least once or twice. If you happen to be in an exclusive relationship, that's fine. You're not going to be exposed to these things. But if you're not, you should get yourself checked out. That's the key message.
So in terms of gonorrhea with this resistance, what are you offering now? What's the way forward now?
So we've changed the way that we manage gonorrhea. So until recently we just used to do PCR, but now we need to do culture and sensitivities as well, because if the gonorrhea becomes resistant, then that's the first place it will appear. The other thing is that's happening in terms of gonorrhea is we're moving into trying to diagnose gonorrhea through gene technology. So if you take gonorrhea, for instance, if there's a GYRA mutation, then it's going to be resistant to first line. It's going to be resistant to drugs like ciprofloxacin. So what we tend to do then is recommend using ceftriaxone as a first line treatment. However, if the mutation is absent, then the gonorrhea is still sensitive to ciprofloxacin, which is a easier antibiotic to deal with. So we move you down that path. So we're trying to hone down on the organism itself and what type of organism people have. The other thing we do is we're waiting for the results of tests to come back. So if someone has horrible symptoms, you're going to deal with those. But if someone is asymptomatic, we wait for the results to come back, and then we treat according to the organism. You know, or even if someone has mild symptoms, we may say, look, we will have the test results available within 24 to 48 hours. Let's give you some symptomatic relief, and then we'll deal with the organism if there is an organism. And that's because between 40 and 60% of people who have genital symptoms do not have an organism that should be treated. So that's how we're dealing with gonorrhea. We're trying to wait for the results. We're using therapy for seeing what kind of infection we're using lab techniques to see what kind of infection they have. Then we're trying to tailor the treatment. It's the same with mycoplasma. That's the same approach we use. If someone's diagnosed with mycoplasma, we try and work out what class of antibiotics the infection is resistant to, and then we give the appropriate antibiotic.
Right. I don't think many people know about Mycoplasma genitalium. Would you be kind enough to explain the kind of symptoms people experience if you got the infection on board?
Well, again, Mycoplasma genitalium is like all other infections. It's mostly asymptomatic. But if people have symptoms like pelvic inflammatory disease or urethral irritation or cervicitis or proctitis or those kinds of things where we then kind of test them for Mycoplasma genitalium.
That's
We
right.
don't test asymptomatic people for Mycoplasma genitalium, and that's because we're not sure about how asymptomatic MG works in producing symptoms. We just don't have that information.
Okay, all right. All right, so in terms of complications, let's say for syphilis long term, why is it important that we treat it? Why is that?
Syphilis is important because, because of vertical transmission. I mean, many countries in the world. I mean, New Zealand is another country where you don't think about syphilis being important outside of the general population, but they've had a run of babies with congenital syphilis. Syphilis also has neurocognitive effects, and the neurocognitive effects can appear usually as early as 8 to 10 years after the initial infection if it's not being treated. And this is of relevance because in Australia we are having young girls and boys as young as 12 being diagnosed with syphilis. So if that syphilis is not dealt with appropriately, by the time they're 20, you will begin to see some neurocognitive effects. So you can get neurocognitive effects. Syphilis is an infection that affects all the systems in the body. So you can get cardiovascular issues, you can get bone issues, you can get spinal cord issues. So that's why you need to treat. That's why you need to treat syphilis. Because of its immediate consequences to the child, but also to its long-term consequences.
That's correct.
To individuals. And we've, I think, recently had a 50-year-old who was diagnosed with dementia, and it was put down to syphilis.
Syphilis,
And we're not sure about the history because we don't know when she acquired it.
But at that stage, it's too late.
It's
anyway.
too late.
It's too
and
late for
treating syphilis at that point is not going to reverse, reverse those issues.
That's good. That's all right. So no, that's fantastic. In other issues, I mean, we see as well in primary care is the genital warts as well. It's very common. Now talking about the risk factors, we talked about the risk factors: intravenous drug usage, and also multiple partners, GG partners. Like you say, we are what's called unwittingly spreading the disease because you're asymptomatic. You don't know that you're a carrier of the disease. So that's one of the risk factors here. Now, prevention. What's your target? Because all this, I mean, there's a deluge. There's a trend is going up in England. In here, you just said Australia is now leading. So
I think
where are we going from here?
Prevention is a difficult. I think prevention is a difficult topic because we're not clear what works. If you look at the randomized controlled trials of community education or provision of condoms, the evidence is not very good. I mean, certainly, we talk about just globally, people talk about abstinence, behavior change in condoms. Well, none of those things condoms we know work, but they have to be used appropriately.
Yes.
But do they work at a population level? We don't know. Behavior change certainly is very hard to achieve, and abstinence is a pointless activity because when George Bush was in power, the key message there was abstinence. And what they found was that as soon as the adolescents stopped being abstinent, their rates of infection shot up enormously.
Right.
So the new ABC, that we talk about antiretrovirals because HIV is a big issue.
Yes.
We talk about barriers. We no longer talk about just condoms. We talk about all forms of barriers. We talk about barriers in terms of condoms, but we also talk about barriers in terms of intervaginal, vaginal preparations, multi-purpose devices. There's a whole range of things. And the other big thing is circumcision. Circumcision is certainly important for for HIV, and there is some marginal effect in other infections. Now, it is difficult to talk about prevention because, with all due respect to governments, they do not invest enough in health promotion. Here in North Queensland, for instance, the curricula around sexual health in schools is poorly designed, poorly executed, and therefore not worth what's So this space is a very open space. Everyone talks about prevention, but in terms of sexual health, it's not like stop smoking and things get better.
No.
Sexuality is complex. The other area I think where we fall down on is sexuality itself. We don't talk about sexual pleasure enough. We don't talk to our children enough. It's all about, gonorrhea and chlamydia, but I think we need to start addressing the other issues around, what is sexuality? What are you comfortable with? And what do you need to enhance your own sexuality? How does pleasure and disease interact? So those are very complex conversations that can't be encompassed into slogans like abstinence, behavior change and condoms. I'm sorry, it's a long-winded way of saying I don't know the answer.
That's right. But there's still controversy about at what age can you introduce sex education in schools? At what age? Surely 6-year-old, 7-year-old?
You can introduce it at any age. It depends on how appropriate you are. If we've got 12-year-old girls getting syphilis, we need to start talking to them about sex in an appropriate way. And certainly I can't do it, because me relating to a 12-year-old is going to be a difficult conversation.
That's right.
You're from Zimbabwe. In Uganda, in order to attenuate the HIV epidemic, they started sex education in schools at the age of 5 and 6. They started talking about the things that mattered at that age. So it is possible to take it down, and we were having a conversation about transgender earlier, and we have kids as early as 7, 8 or 9 who are presenting to us with gender issues, and we need to start addressing their issues around sexuality as well. So I think it's something that we're not prepared to talk as a society.
That's right.
And so we need to learn how to talk to our children about sex. I think the age is irrelevant. Okay. You have to have the right words and the right combinations of things to say.
I was reading one paper saying family education or family intervention in the family, where you share these topics, talk about this, you talk to your daughter, talk to your son, father to son maybe, or father to mom to daughter, and that's fine. They're saying it is just as effective as health professionals talking to the kid. They say it's very effective. So do it at home or peer-to-peer. Maybe talk to a friend in more detail, or talk to the big brother, big sister, maybe educate down the trend. But it's easier in the family setting, I think.
It's only easier in the family setting if the family setting is geared up for it. So if the family is deeply religious, or they have they have issues around sexuality, then it's not going to happen. Now, I work in Papua New Guinea. Papua New Guinea has the world's highest rates of gonorrhea and chlamydia and a whole range of things, including HIV. It is such a heavily Christian society. There are 7 or 8 different churches. Everyone there, from the Catholics right down to the Seventh-day Adventists. Those conversations will not be held in those families.
That's right.
So the implication of what you're saying is that the family is willing to talk about these things, and that there is a context and a structure to allow that to happen.
To allow that,
and I'm afraid that's not happening at the moment.
Now, and then obviously social media takes the lead. Now people learn from social media, they're on their phones and iPads or whatever, they learn from the social media, and what they learn sometimes is not that great. It's not informative enough for them. And the media becomes the leader. It becomes the parent, becomes the big brother, the big sister. And then that's how you lose it completely. So Yes, it's a difficult topic one, which is why we bring some of these topics here on the show, so we can bring some controversy in, we can stimulate debate. You know, people need to talk about these things. Yeah.
They certainly need, I mean, I think we need to talk about sex. We need to find a different language to talk about sex. I mean, one of the, and you know, you're right, a lot of young people learn about sex from, you know, not only their peers, but from watching porn, from the internet sites, from a whole range of things. Yeah. And all those things, I'm not saying they're totally inaccurate, but they can distort sexuality.
Yes.
I don't know if you ever watch Netflix, but there's a wonderful series on Netflix at the moment called Sex Education. And it's based around some teenagers in a school, and you know, the key protagonist in there, the mother is a sex therapist, and they do actually talk about some of these issues in a way that's really quite interesting, and you can see the impact of social media, you can see the impact of peer pressure on these individuals. Yes, we have to learn a different language, we have to talk about it differently. And I think we can't talk about prevention if we don't talk about sexuality, about pleasure and all those kinds of things, about diversity. You know, and that's one of the key things I've learned in my time my time in sexual health.
Yes, that's good. That's good. That's all right. Well, I think I haven't got much to bring upon you. I'm certainly going to drag you again for another topic.
Sure, I'm happy to come and talk about it.
Yeah, it has been a pleasure having you on the show, Dr. Menon. We thank you for coming up.
Thank you.
And for everybody else watching, we appreciate you joining us on the Doc Dave Show. And yes, we bring these kind of controversial topics. They should be discussed. We have to discuss, and that's the only way we can move forward. We want to stimulate debate, we want to educate people, we want to raise awareness. So I hope you've picked up one or two things. We always put a disclaimer on this. Here, we are not prescribing anything to anybody. Dr. Menon is here in his own capacity. He's not representing anybody. He's expressed himself from his clinical experience. So if you've got issues which you think need to be discussed, please consult your health provider, healthcare provider. It could be a general practitioner, it could be a nurse, to get some more information.
Could be a sexual health clinic.
Sexual health clinic in your neighborhood. Look for somebody will help you out. So anyway, thank you so much for joining us on the Doc Dave Show. Keep safe, keep well, and God bless you. Bye-bye for now.